Most of you may be familiar with the ACE inhibitors. The ACE inhibitors are a class of drugs which end with the word pril, like enalapril, perindopril, ramipril, lisinopril, quinapril, captopril. So, these prils are angiotensin converting enzyme inhibitors or ACE inhibitors. Among them, the molecule that is most studied, most widely used is of course ramipril. Now, in the next slide, we will see about the angiotensin receptor blockers or ARBs. ARBs are angiotensin II receptor blockers. These are a class of molecules which block the action of angiotensin II at its type 1 receptor, and these end with the word usually the sartan. So, these are the sartans: losartan, candesartan, olmesartan, irbesartan, valsartan and telmisartan. Here the prototype molecule or the flagship molecule is losartan, just like ramipril is the protomolecule of ACE inhibitors. Losartan is the most studied of all the sartans. Of course, we now have two other upcoming molecules, the olmesartan and the telmisartan, on which we have enough literature warranting their use in clinical practice. So, we will come back to discuss about these things a little later, to use which sartan or which pril, or whether to use pril or sartan or a combination. All these issues we will discuss in our subsequent slides. It is essential for all of us to understand the renin angiotensin aldosterone system, also called the RAAS. Without a lucid understanding of the RAAS, it is not possible to understand and utilize the benefits of ACE inhibitors and ARBs in our clinical practice. The most important molecule, of course, the one which causes lot of problems in our body in the pathological conditions, is the angiotensin II. This angiotensin II is not directly produced from any part of the body, but it has to be synthesized from its promolecules. So, we now have the molecule angiotensinogen. This angiotensinogen is a globular protein. It is not a chain, it is a globular protein, and this is produced from the liver. Angiotensinogen, under the action of renin, which is another enzyme, a protein enzyme, secreted from the juxtaglomerular apparatus of the kidney. From the juxtaglomerular cells, under the influence of various stimuli, renin is released, and this renin favors the conversion of angiotensinogen to angiotensin I. This angiotensin I is not an active molecule by itself. It has to be further converted into angiotensin II, which is the most vasoactive molecule. Angiotensin I contains 10 amino acids and that is why it is called a decapeptide. Now, for the conversion of angiotensin 1 to angiotensin 2, we require 2 amino acids to be removed from the decapeptide and an octapeptide has to be formed. And this cleavage of angiotensin 1 into an octapeptide from a decapeptide is done in the lungs by the enzyme called angiotensin converting enzyme, also called ACE or simply called ACE. So, in a nutshell, angiotensin 2 is the most vasoactive molecule. This angiotensin 2 has to be formed from angiotensin 1. Angiotensin 1 is converted to angiotensin 2 in the lungs by the action of ACE enzyme. ACE also is a protein enzyme, it is a peptide enzyme containing 2 zinc groups. One of the zinc groups is active and that is the one which converts angiotensin 1 into angiotensin 2. But for the formation of angiotensin 1, we require renin, which is secreted from the juxtaglomerular cells of the renal glomerulus. And this angiotensin 1 is formed from the angiotensinogen, which is secreted or formed from the liver. So, these are the 3 fundamental basic steps through which angiotensin 2 is formed. The drugs, the pills, ACE inhibitors inhibit this enzyme ACE, and once this enzyme is inhibited, the formation of angiotensin 2 from angiotensin 1 is affected and the molecule, danger molecule angiotensin 2 is not formed in large amounts. With the result, ACE inhibition or ACE inhibitors reduce the deleterious effects of angiotensin 2 on the vasculature, on the kidney and on the heart. In the previous slide, we have seen the most important vasoactive molecule is the angiotensin 2. This angiotensin 2 acts via 3 receptors. 3 subtypes of receptors are available: angiotensin 1 receptor, angiotensin type 2 receptor, angiotensin type 4 receptor. They are called AT1 subtype, AT2 subtype and AT4 subtype. Remember, AT1, AT2 and AT4 are all the subtypes of receptors on which the angiotensin 2 acts. Angiotensin 1 itself is not a vasoactive molecule. It is only the angiotensin 2 which is the vasoactive molecule, and it acts and mediates its action through one or other of these 3 receptors. We know very little about this AT4 receptors at the moment, and it is believed that action of angiotensin 2 on AT4 receptors is beneficial. But we very much know that the AT1 subtype receptor through which the angiotensin 2 mediates its vasoactive and vasodestructive actions, they are very harmful to the vascular tree, to the heart, to the kidneys, of course to other organs of the body. So, it is the activation of the angiotensin 1 subtype receptor through the angiotensin 2 that it causes harmful effects, and we have the drugs called the angiotensin receptor blockers, which will bind onto the AT1 subtype of the receptors and see that the angiotensin 2 does not have the chance to attack these receptors and produce the harmful effects. That is how angiotensin receptor blockers are vasoprotective and exert their antihypertensive and other actions. Of course, angiotensin 2 in turn stimulates the adrenal cortex to produce aldosterone. Aldosterone has got several mechanisms of activation. Aldosterone stimulation is through the angiotensin 2, through the decreased sodium levels in the blood, hypovolemia, increased potassium, and of course from the pituitary ACTH. So, the action of ACTH, low sodium, low blood volume, high potassium, of course angiotensin II itself, all these will act on the adrenal medulla to synthesize more of aldosterone, and which in turn retains fluid, retains sodium, excretes potassium, and aldosterone, in addition to its renal effects, has also got vascular and then cardiac effects which are deleterious to the system. So, the final common pathway of RAAS in producing damage is to the angiotensin II, and that angiotensin II has got two routes, one through the AT1 receptors which produces all the harmful effects, and also through the aldosterone pathway, secreting more of aldosterone, it produces deleterious effects. Supposing we have drugs which block the AT1 receptors like ARBs, and we also use drugs which block the action of the aldosterone, then we will be left with the action of angiotensin II on the other two types of subtypes of receptors, the AT2 and the AT4, whose effects are beneficial. So, this is how we require to know the action of these drugs. ACEs in the previous slide we have seen, and the angiotensin receptor blockers in this slide. Now, it is important for us to know that there are certain non-ACE pathways for the formation of angiotensin II. Look here, this is angiotensinogen from the liver. For the angiotensinogen to be converted into angiotensin II, it can go through this route of angiotensin I and then become angiotensin II, for which we require two enzymes, the renin from the juxtaglomerular cells and the ACE in the lungs and the vasculature. The angiotensin converting enzyme converts angiotensin I to angiotensin II, renin converts angiotensinogen to angiotensin I. So, this is the normal pathway. Angiotensin I under the action of renin becomes angiotensin I, angiotensinogen under the action of renin becomes angiotensin I, which under the action of angiotensin converting enzyme in the lungs forms angiotensin II, which is the vasoactive and the danger molecule. Now, can this angiotensin II be formed without going through this pathway? Yes, it is possible. Some of the angiotensinogen gets converted directly into the angiotensin II, which is the octopeptide, and this pathway or these pathways are called the non-ACE pathways. These non-ACE pathways are to generate angiotensin II from angiotensinogen. What are the pathways? The TTPA pathway, the cathepsin G pathway, the tonins, the elastases, the chimases, the enzyme Ks. These are the different pathways through which the angiotensinogen can get converted directly into the vasoactive molecule angiotensin II, which can further produce vascular damage. So, even if we block the ACE pathway by using ACE inhibitors, we still have a chance that angiotensinogen can get converted into angiotensin II through one or other of these pathways, of which the most important one is the chimase pathway. Now, very recently in the year 2008, another angiotensin converting enzyme called the angiotensin converting enzyme 2 has been documented, synthesized and then investigated, and its effects on angiotensin I are to convert that into angiotensin I within brackets 1,7 peptides, and this is containing, instead of being the 10 peptides here getting converted to 8, it is only a 7 peptide chain, and then 7 amino acid chain, and this 8117 is vasoprotective, is helpful to stop some of the detrimental effects of angiotensin II. Now, supposing if we have drugs which can augment the action of ACE2, they will be beneficial for the vasculature. In fact, human recombinant ACE2, HRACE2 it is called, is synthesized, and that is used to ward off the renal destructive effects of angiotensin II and to promote this pathway and see that this vasoprotective molecule is increased in its quantity, and the effects of angiotensin II are rather stopped or interfered. So, this is a nutshell about the non-ACE pathways of angiotensin II formation from angiotensinogen. What are the various levels or steps at which we can block the RAAS? Fundamentally, angiotensinogen to angiotensin I to angiotensin II, which further stimulates the production of aldosterone. Okay. Angiotensinogen to angiotensin I, we know that renin is the enzyme we require, and that renin can be inhibited by aliskiren. Aliskiren is a new drug, new antihypertensive drug, which inhibits the renin and stops the formation of angiotensin I itself and blocking this RAAS at this very first step itself. Of course, we have the time honored and time tested ACE inhibitors which act on angiotensin converting enzyme, and that they of course will prevent the formation of angiotensin II. And not only they act in this formation, this angiotensin converting enzymes are responsible for the degradation of bradykinin. So, when we use ACE inhibitors, this bradykinin is not degraded because we have interfered with the enzyme. The bradykinin accumulates. Of course, bradykinin increase is vasoprotective, bradykinin is vasodilatory, and it is vasocardio-renoprotective. Whereas, when you have the AT1 receptors activated by the angiotensin II, that one is deleterious to the vascular tree, which can be blocked by angiotensin receptor blockers or AT1 receptor blockers, the sartans. These are the prils, ramipril, enalapril, lisinopril, like that. These are the sartans, losartan, valsartan, telmisartan, olmesartan, like that. Now, of course, we have the renal effects of aldosterone, which can be blocked by mineralocorticoid receptor antagonists. Either you can use drugs which block it at the level of the kidney using spironolactone group of drugs, or you can block the aldosterone action by using MRAs or mineralocorticoid receptor antagonists, which we will see a little detail in our subsequent slides. So, what happens is when we block the AT1 receptor through ARB, the other receptors AT2 and AT4 which are left unblocked, and the angiotensin II that is available acts on those receptors, and we know that these two receptors are favorable to the body and they are vasoprotective. Likewise, either when you use the ACE inhibitor, you increase the bradykinin which is vasoprotective. When you use an ARB, you increase the AT2 and AT4 receptor activity, which is again vasoprotective. That is how the RAAS blockade acts as vasoprotective, not only by reducing the aldosterone formation through the angiotensin II, but also by increasing the bradykinin through ACE inhibition, increasing the AT2 and AT4 receptors through AT1 receptor blockade. Any one of these steps, and of course, if we use a newer drug here, the renin and inhibitor aliskiren, all these effects can be stopped or blocked to a greater or lesser extent. But of course, the experience with Kinin, it's a new drug, we do not have enough experience. We require more trials to document its vasoprotective, cardioprotective and renoprotective effects. Now, let us see a little bit about the synthesis and metabolism of kinins. In the tissues and in the plasma, we have got the promolecules kallikreins, tissue and plasma kallikreins. These are acted upon by kininogenase. Kininogenases convert the kallikreins into lysine bradykinin. This lysine bradykinin is converted into bradykinin, and this bradykinin has to be degraded, and for that we require kininase 1 and kininase 2. This bradykinin is a vasoactive kinin, and if the bradykinin is degraded by kininase 1 and kininase 2, it is metabolized and its vasoactivity is reduced. Bradykinin as such is a helpful molecule, and if we can block the kininase 1 or kininase 2, we can see that the bradykinin levels increase, giving a beneficial effect. This ACE inhibitors or kininase 2 ACE inhibitor angiotensin converting enzyme acts as a kininase 2. So, if we give ACE inhibitors, this kininase 2 or the ACE is blocked, so much so the formation of bradykinin will be more in the body, and its destruction or metabolization is stopped by the K2 pathway. With the result, bradykinin accumulates. It is believed that this excess bradykinin in the body is helpful very much for the vascular as well as for the cardiac and renal tissues. However, the accumulation of bradykinin in the lungs can produce certain side effects related to ACE inhibitors like the cough, or sometimes the vaso effects of bradykinin can result in what is called the angioedema. It is believed that the two common side effects of ACE inhibitors, the angioedema and the dry cough, are probably due to the increased levels of bradykinin, which is not allowed to be degraded because the kininase 2 enzyme is blocked by the ACE inhibitor that we have used. This is a pictorial representation of the juxtaglomerular apparatus. Juxta means near, in proximity to the glomerulus. That is why they are called juxtaglomerular cells or apparati. And these cells release what is called pre-prorenin, and that pre-prorenin is converted into prorenin, and the prorenin is converted into renin, which acts on the angiotensinogen to form the angiotensin 1, and then of course through that angiotensin 2. So, that is how the effects of juxtaglomerular apparatus are mediated through into the glomerulus, and it will lead to sodium and water retention and through the aldosterone, and vasoconstriction through the angiotensin 2. So, these are the various effects of juxtaglomerular apparatus renin secretion. So, to summarize the physiology of the renin-angiotensin system, we have the liver here, which produces the angiotensinogen. That angiotensinogen requires renin. This renin is released from the kidneys, the juxtaglomerular cells of the kidney under various stimuli, and that renin converts angiotensinogen to angiotensin 1. This angiotensin 1 is not vasoactive. This requires the help of an enzyme called angiotensin converting enzyme, which is on the pulmonary and renal endothelium, mostly in the lungs. And this angiotensin 1 is converted by the action of ACE to angiotensin 2. So, this angiotensin II is, remember, is not a simple molecule. It has got several activities. It will be sympathomimetic and increases the sympathetic activity. It acts on the kidneys to conserve sodium and chloride, reabsorption and then excretion of potassium and water retention, and that causes volume overload. It acts on the adrenal cortex to release aldosterone. Aldosterone further augments sodium and water retention and potassium excretion. It acts on the arterial artery to produce vasoconstriction, increases the blood pressure, the arterioles are damaged. It acts on the endothelium also to produce negative effects on the endothelium and decrease the nitric oxide production and produces endothelial dysfunction. It acts on the pituitary, posterior pituitary, and increases the secretion of ADH. This antidiuretic hormone acts on the collecting duct of the renal tubule, retains more water. All these effects of angiotensin II mean water and salt retention, increase in the effective circulatory volume, perfusion of the juxtaglomerular apparatus increases, which in turn is supposed to inhibit the release of renin through the kidneys and then stop the production of angiotensin I. This is the feedback loop. But in pathological states, what happens is this water and salt retention, vasoconstriction, sympathomimetic activity, and then the endothelial dysfunction all culminate in vascular damage. So, to simplify the information provided in the previous chart, sympathetic stimulation, hypotension, decreased sodium delivery to the kidney result in renin production. Renin converts angiotensinogen of liver into angiotensin I. S enzyme, angiotensin converting enzyme in the lungs and the renal endothelium, that converts A1 to AT, which is a danger molecule. This A2 or angiotensin II acts on the adrenal cortex, produces aldosterone, increases further water and sodium retention, acts on the pituitary via ADH, increases fluid retention and sodium retention. AT2 stimulates thirst, increases the blood volume by making you drink more water. All these end in hypervolemia, hypernatremia, and of course AT2 angiotensin II is systemic vasoconstrictor and it acts on the endothelial cells of the vessel wall to produce endothelial dysfunction. On the heart, it acts on the cardiac and vascular tree to produce hypertrophy of the cardiac muscles. With the result, there will be remodeling of the heart that occurs due to excess of angiotensin II. Remember, this angiotensin II is the danger molecule and we need to stop its deleterious effects either by interfering with the SEE or by interfering with the angiotensin II receptors themselves by the angiotensin II blockers, or at the level of renin, or give aldosterone antagonists.